Good evening, everyone. How are you all? So welcome to First Aid AMC Clinical free 2-week session again. And this is our last class of this free 2-week session, right? So we have done a couple of clusters already, and you guys already know how we are doing the classes. And I hope that this free 2-week session helped a lot of you, like at least to understand how AMC Clinical works. Now, tonight we are going to start another cluster, which is a little bit different from what we have done so far. So we have done medicine, we have done psychiatry. Tonight, there is another cluster, which is mainly from pediatrics, vomiting cluster. It's one of the very commonly asked cluster in exam. So we will go through this and try to finish it in one class. Before we start, I would just like to give you some idea about the course so that you guys have some information beforehand. I understand that most of you are already enrolled in the course in here. So please make sure that if you already make the payment, you should check that you are already in our Facebook course group, which is not the official group called First Aid AMC Clinical, but there is a course group for batch 6. So if you are not added to that group, please make sure that you send me a message or email so that I can have a look at why you are not added yet. And also, if you haven't made any account in our portal yet, you have to make sure that you do that. And once you make your account, then just let us know that you are waiting for the approval for access. Because in our portal, you will get all the course materials and the recording of the classes. And there is an orientation class coming up on 20th of July, so next Wednesday. So make sure every one of you who have already joined the course, make sure that you get into that class, because we will discuss how the course works, what you are going to do, and everything about the AMC Clinical. All right. So that's all about it. And one of the good news is that I hope that you know that in June clinical exam, there were 8 students who passed. Now we have got 2 more. So now it's 10 students who appeared the exam and they passed the AMC clinical in just June month. So you can understand that how good it is, because I don't think that there is any course, even in total, they don't get 10 students to get passed in a year. But in our course, we have 10 students who just passed in 1 month. So obviously you understand that how we deal with the students, how we make sure that your preparation becomes so solid and you become so confident in the exam that you appear the exam and you pass it, which is not very common, because if you are aware of clinical exam pass rate, it is not very good. But our students' pass rate is really, really good, because most of them were first-time candidate. And years ago, it was a dream to pass clinical exam in the first attempt. But now, with our help and obviously our students' hard work, this is possible. So it's actually a very good month for us, I would say. All right, so let's start our class tonight. So it is pediatrics vomiting cluster. As always, what are the differential diagnoses for a child who present to you with vomiting? Especially if it is an acute onset of vomiting, we divide it into 2 things. Is it a GIT related or it's a non-GIT related? GIT related causes are like, it could be gastroesophageal reflux, it could be pyloric stenosis, it could be duodenal atresia, it could be incarcerated or obstructed hernia, intussusception, volvulus intestinal obstruction or Hirschsprung disease, acute gastro, would be esophageal atresia or tracheoesophageal fistula. Now, a lot of things to remember, but the important cases for exam in terms of vomiting is pyloric stenosis is very important. Duodenal atresia comes in exam. Hernia comes in exam. Intersusception comes in exam. Intestinal obstruction, Hirschsprung comes in exam, but not very common. Gastro, not too much. Tracheoesophageal fistula comes in exam. You can see that, and also gastroesophageal reflux. So you can see that every differential that you can see in here, it comes in exam. So that's why it is really, really important cluster for you. In terms of non-GIT causes, because children can present to you with vomiting if they are having any infection in their body. So always try to find out any infectious causes. So most importantly, UTI, then otitis media, septicemia or meningitis, pneumonia, and sometimes torsion of the testis can present as vomiting. So non-GI causes is always important. If you get a patient who is having fever and vomiting, then these non-GI causes will be very important to rule out. Okay, so these are the main differential diagnosis for vomiting in a child. Now let's move on to the history. Now, always remember, just like your psychiatry, psychosocial history that we have done, that has a format that you can use in every psychiatric history, right? Same in pediatrics, we have a format that you can use in almost every pediatrics history. So the format is, so first, obviously, we will start with our HOPC, which is the history of presenting complaint. Obviously, in pediatrics, one of the important thing is how you introduce yourself with the parents. Because in exam, there will be no child as a role play. The role player will be the parents. So either the mom or dad will come here to talk about the child. So you will not see any child in the exam. Okay? So parents will be very concerned about their child, especially if they're vomiting. So you have to make sure that you reassure them, make sure you say something nice and good so that they become assured that, yes, I am with a good doctor. So you always start like, hi, Jenny, this is Dr. X, one of the doctor here. It's very nice to meet you and Sam. Let's say Sam is the child name. I understand from the notes that Sam has been vomiting for the last 2 days. It must be very stressful for you and also for Sam. But please don't worry. Now that you are here, we are going to find out why he's having vomiting and we'll try our best to manage his symptom. Now, before I start, I would like to make sure that if Sam is vitally stable first, because he's vomiting a lot. So for face-to-face, we will go back to our examiner and ask, dear examiner, is my patient vitally stable for further history? So what you want to know? For children, you want to know the blood pressure, pulse rate, temperature, respiratory rate, saturation, and any sign of dehydration. So for children, one of the other important things is the sign of dehydration, especially if they are vomiting or having diarrhea. Once you know that child is stable, then you go back to the parents and ask that, all right, thank you so much for waiting. Now, would you please tell me a little bit more about these vomiting episodes? So the parents will give you some idea that, yes, doctor, he's been having vomiting for the last 2 nights and it's just getting worse. So we are very worried about it. So you ask that, well, how many episodes so far? If you don't know when did it start, then ask it that since when it start, how many episodes so far? We always follow CCVO for any kind of discharge from the body or any kind of, you can say, vomiting, diarrhea, any PV bleeding, anything which is coming out of the body, we use this CCVO. And CCVO means color, consistency, volume, and odor. So what is the color of the vomitus? Have you noticed any blood in it? What is its consistency? Is it very thick or thin? Or you can say that is it very thick or watery? Now, consistency of vomiters is not very important, rather content is more important. So you can say that what was the content of the vomiters? That means what did it contain? Like is it a breast milk, or is it something that you have given to him? So what's the content of the vomiters? Rather than asking thick and thin. Is it a small or large in amount? And how is the odor? Is it very foul smelly? Okay, so what is the color of the vomiters? Have you noticed any blood in it? What is the content of the vomiters? Is it a small or large in amount? And is it very foul smelly? Couple of other things that we need to ask in vomiting question is that, is it forceful or projectile? Forceful projectile vomiting sometimes indicate pyloric stenosis. So that's why we ask it. Is there any relationship to feeding? If yes, then how long after feeding does he vomit? Usually children with gastroesophageal reflux, they vomit just after feeding. And sometimes not just vomiting, just like having some spitting. So that's gastroesophageal reflux. And does he become hungry or does he cry immediately after feeding? So if the child becomes hungry or cry immediately after feeding, that suggests that everything that you are giving to the child, they are just puking it out or they're just vomiting it out. And sometimes that's usually a feature in pyloric stenosis children. So they just become hungry because everything that you are giving, child is just vomiting it out. So these are the three questions important for pyloric stenosis and also gastroesophageal reflux. So we will ask that, is it forceful or projectile? Is there any relationship to feeding? If yes, then how long after feeding? And does he cry or does he become hungry immediately after feeding? So that's your A2PC, vomiting question. Then along with the vomiting, have you noticed any tummy distension or swelling? Any lump or bump in the tummy or in the groin? Now, I always say that associated symptoms, if you don't remember it, it is fine, because most of the time this is one of the differential diagnoses as well. Like tummy distension usually falls under intestinal obstruction. So if you don't remember the associated symptom, it is totally fine. From HOPC, you can directly go to the differential diagnosis also. So the format would be vomiting, then differential diagnosis. Start with the bowel and bladder. So bowel, especially, it will give you an idea about the intestinal obstruction. So how about his bowel habit? When was the last time he passed or he opened his bowel? Any history of diarrhea or constipation? And along with that, you can also ask this question: have you noticed any tummy swelling or distension? So children with intestinal obstruction, they will have constipation. They will obviously, they will say that, yeah, like last opening of bowel was 3 or 4 days ago, and there will be tummy distension also. So that's intestinal obstruction. Then go to the waterworks or bladder habit. So how about his waterworks? Any change in number of wet nappies? Any change in color or smell of the urine? And does he cry while passing urine? Now, there's a lot of question. When you come to the waterworks or bladder habit, it gives you two things. One, you are ruling out UTI, and you're also getting some idea about the volume depletion or dehydration of the child. So how about his waterworks? Any change in color or smell of the urine? UTI children, the smell will be very, like, not very usual kind of smell. The smell will be kind of like a foul, smelly urine in UTI. And obviously, child can't say that I'm having pain during passing my urine. So they will cry when they are passing the urine. That indicates that most likely it's burning when they are peeing. Okay, so And any change in number of wet nappies, children who has decreased number of wet nappies, especially on the background of any infection that suggests that they are not eating properly, or especially they are not drinking properly, that means that they are dehydrated. So that's why we ask this question, any change in number of wet nappies? If they say yes, if it is reduced in amount, then think that child most likely is dehydrated as well. So we have asked about bowel and bladder. The next is some of the other differential diagnoses. So we have got intersusception. So you can ask that, does he draw up his legs while crying? Does he turn pale while crying? Children with intersusception, they present to you with episodic screaming episode as if they're in severe abdominal pain. And because they can't say that, so they usually draw up their legs up to the chest. And sometimes also they clench their fist. And during the episodes, they usually turn pale. So those are the symptoms of intersusception. Along with that, children also can have some diarrhea in intersusception. We will discuss all of these cases, then you will know much detail about this. Then we have some of the non-GI causes. Before going to the non-GI causes, just think about if we have missed any GIT-related causes. So there was one differential, which was incarcerated hernia. So we already asked it, any lump in the tummy or in the groin? So lump in the groin, that suggests hernia, okay? Now, if you go back to the differential, for reflux, only thing that you will get is vomiting. Pyloric stenosis, forceful projectile vomiting. Duodenal atresia usually presents just after birth. Same with esophageal atresia, present with vomiting just after birth. So it's very unlikely to get it in like after 2 to 3 weeks. We will go through this duodenal atresia and esophageal atresia later on. Incarcerated hernia, we are asking about lump in the groin. Intersusception, we asked. Intestinal obstruction, we have asked. Gastroenteritis, we actually asked. Like we asked about fever, we asked about vomiting already, and we asked about any diarrhea. So that's gastroenteritis. So all of the GI causes are already done. Now you have non-GI causes. So for non-GI causes, you will ask that, have you noticed any fever, any rash in the body? That's for septicemia, especially for meningitis. So any fever, rash. For otitis media, have you noticed that he is pulling his ears a lot and any discharge from the ears? For pneumonia, any cough, any difficulty in breathing. Okay, so that's your non-GI causes, or especially you are trying to rule out any infectious causes of diarrhea. Sorry, infectious causes of vomiting. And then you are going to finish every pediatric history with these things. So what are these? Called well baby questions, binds, TMAC, past medical history, and family history. Now for well baby question, we have few things that we normally ask. You have a discussion about this in detail in our respiratory cluster. So in the respiratory note, you will get all of this in detail. So let me just discuss it. So well baby question has 4 or 5 questions that we normally ask. One of them is mental status of the child. Then we ask about their feeding and sleeping. So sleeping and feeding. Then we ask about their bowel. We ask about their bladder. And sometimes you also ask about any weight loss. So this is called well baby question. Every baby or every child, we ask these questions. So for mental status, the question that we ask is that, is he active, alert, or drowsy? So if the child becomes drowsy, that suggests that it is very severe condition. If child is active, alert, it is not a very severe condition. So mental status is always important in case of any acute presentation. Is he sleeping and feeding well? If a child is sleeping and feeding well, that suggests child is well. We already asked about their bowel habit and water works. And you can ask about this, like, have you noticed any change in their weight? Or have you noticed that he is losing weight? Weight loss is particularly important in vomiting cluster because in case of pyloric stenosis children, you will get that child is losing weight or not gaining appropriate weight. So that's a very important question, that have you noticed any change in his weight? After well baby question, we have binds. So binds again has a lot of questions to ask. One is birth history, I for immunization, N for nutrition, D for developmental history, and S for social history. So that's called binds. Now, we normally don't ask all of these questions. We only ask the relevant questions. So for birth history, we will just ask that, how was the birth? Or you can ask that, so how was the birth history? Or how was the pregnancy and delivery? Was there any complications? Was he a term baby? Okay, so birth history, normally we ask that, how was the birth history? Was there any complications during pregnancy or delivery? Was he a term or preterm baby? Is he immunologically up to date? Nutrition, normally not important in this case. For development, is he growing and developing well? Social history, for vomiting cluster, it is not very important, so forget about it at the moment. So birth history, immunization history, and developmental history, these three is important and relevant to this case. So how was the birth of the baby? Was there any complications during pregnancy or delivery? Was he a term baby? Is he immunologically up to date? Or if his vaccines are up to date, is he growing and developing well? After binds, then we have TMAC. TMAC consists of travel history, then medication history, then allergic history, and C for contact. Okay. Now, travel history is very important nowadays because of the COVID era. It is very important. Almost everywhere we normally ask these questions nowadays. So travel history and seek contact. So any recent travel to anywhere? Is he on any medication? Any known allergies? Any contact with anyone having similar complaint? Okay, so any contact with anyone having similar complaint. Sometimes we can also ask in the way like, does he go to childcare? Anyone at childcare having similar symptom? Anyone at home having similar symptom? So that's called contact history. Very important because sometimes this thing can be contagious or infectious, especially from childcare. Children usually get a lot of conditions in here. So very important is to ask about the contact history. Any past medical history, any family history of any chronic disease. Okay, so that's how you finish your pediatric history. So the format is you start with the reassurance. If acute condition, make sure child is vitally stable. Then ask about the HOPC, and then ask about the differential diagnosis. In vomiting cluster, first GIT causes, followed by non-GIT causes. And lastly, finish with well baby, binds, TMAC, past medical history, family history. Now, you might be thinking that how I'm going to finish all of it in the exam. It is tricky always. This time thing, it needs a lot of practice. So if you do a lot of role play with your study buddy, you will understand how to manage the time. And again, it always depends how many tasks have you got in the exam. If you have got only 2 tasks, like history for 6 minutes and then give the diagnosis and DD, then you can ask all of these questions. But if you have got 3 or 4 tasks, then you will not ask everything that is written in here. You have to cut it short. Okay, so that's all about the history of vomiting cluster. Any question, guys? And what is the significance of order of vomiters? Actually, there is no significance. So we just ask it, but it's not very important question. So vitals, Dr. Najia, it's pulse, blood pressure, respiratory rate, oxygen saturation, temperature, and sign of dehydration for children. Food poisoning can come as a DD, but usually it will get covered with the gastroenteritis. All right, any question, guys? We can move on to the cages. Now, what I want you guys to do, just close your eyes and think about what is the format of vomiting cluster history. So I'm going to give you just 1 minute to do that, and then we are going to start the case. This is the way to remember things. Okay, so 1 minute. All good. So do we specifically ask the sign of dehydration? Yes, we do. So we can just ask at the first that, dear examiner, I would like to know if my patient vital is stable for further history. You don't need to ask anything like specifically one by one. So wait for the examiner response. If examiner asks you that, what do you mean? Or what do you want to know? Then you only ask all of this. Otherwise, don't bother. No, that's a good question, Dr. Faisal, that if there is any information in the stem already, then we don't need to ask the same thing again. Like if it is written in the history or in the stem that child has been vomiting for 2 days, are we going to ask again that how long the vomiting is happening? No. So that's also important, that what is given in the stem, we don't repeat it. And let's say if it is written in the stem that child is vitally stable, are we going to ask it again from the examiner? No, because it's already given in the stem. All right, moving on to the cages, and we will also discuss how to do the physical examination for vomiting cluster. So urinary tract infection, very important for the exam. So a mother came with 9 months old female baby with fever and vomiting for the last 2 days. You are a GP. So you have to take history from the mother, physical examination finding from examiner, and give your diagnosis with further management. So fever, vomiting. Remember I say that if you have got fever and vomiting, then your main differential should come as a non-GIT causes or infectious causes of vomiting. So again, you will start with the same history. So you give reassurance, you make sure child is stable, and then start with the vomiting question. So ask all the vomiting question, followed by you have another HOPC here, which is the fever. So ask about it also. So I understand that you have noticed some high temperature in your baby. Since when you have noticed it? Did you measure the temperature? If yes, what was the highest temperature? Have you given any medication? Did it work? Is it continuous or on and off? Have you noticed any chills or shivering? So these are the fever questions. And followed by that, you will go for the differential diagnosis, but now you will start with the infectious causes. So that's how we change our format depending on the question. You always remember one thing, that just because there is a format in our head, it doesn't mean that we will have to follow it exactly in the same way always. If only vomiting, there is no fever, then yes, we will start with the GIT causes, then go to the non-GIT causes. But now already we know that the child having fever. So we will start with the head to toe fever source question. So the source of fever is very important to find out. And in children, it can come from anywhere in the body. So head to toe, we will try to ask questions to find out why child having fever. And throughout the course, you will hear it again and again, that fever source question. So this is the thing that you need to remember. So the source is start with the head. In the head, meningitis, encephalitis. So ask about any, have you noticed any rash? If child is little older, like 3-4 year old, you can ask that does he complain about any headache? Does the light hurt her eyes? That means photophobia, any neck pain or neck stiffness. So those questions for meningitis. So for meningitis, fever, rash, headache, photophobia, neck pain, neck stiffness. Then after head, you have the total upper respiratory tract. So ask about all of it. So start with any itchy or runny eyes, any runny nose, and then come to the otitis media. Any ear pain, or does he pull his ears a lot these days? Have you noticed any discharge from the ears? After that, throat. Any sore throat? Okay. And so you have asked the eye, nose, ear, throat. That's the upper respiratory tract. Go to the lower respiratory. That's for pneumonia. Any cough, any shortness of breath, any noisy breathing. After that, you go to the gut or abdomen. For acute gastroenteritis, you ask all the bowel habit question. For UTI, you ask all the water work question. And then you will ask all other GIT differential diagnosis. So you're just flipping the history format, right? Previously, you started with GIT causes. Now you're starting with the non-GI causes and then going to the GIT causes. Okay, so that's the only difference between the previous and this format. So again, that fever source question, we start from the head for meningitis. Then we ask all the upper respiratory tract, including the eye, ear, nose, and mouth. So for eye, ear, nose, and mouth, we will ask that any itchy eyes or runny eyes or watery eyes, any runny nose, any pain in the ear, or does he keep pulling his ears, any discharge coming out of the ears, any sore throat or any difficulty in swallowing, and then go to the pneumonia, any cough, difficulty breathing or noisy breathing. And then you just go to the bowel habit waterworks, followed by all other GIT causes. And that include your incarcerated hernia, intussusception, all of it. And lastly, finish with well baby binds past medical history and family history. In the past medical history, if you get that, what you will find out in the history that child having fever, vomiting, and you might get that child, like parents has noticed that the urine smell or color has been changed, and also child cry while passing urine. So that's most likely UTI. Okay. If you get UTI history positive, in the past medical history, ask about any previous history of urinary infection or any other kidney disease. Because recurrent UTI in a child, we always try to find out if there is any underlying structural abnormality in the genitourinary tract. Okay, so that's why we have to ask it and ask about any family history of kidney disease. So that's your history. Now, physical examination from examiner. So in case of face-to-face exam, you have to ask physical examination from examiner. So say that, dear examiner, I would like to do physical examination on my patient. I would like to start with general appearance. Is the child alert, drowsy, or irritable? Is there any dysmorphic feature of Down syndrome? Any pallor icterus? Any sign of dehydration? Any rash in the body? Or any skin pigmentation? Now, skin pigmentation is congenital adrenal hyperplasia, which is usually not very important for exam. So don't bother with this too much. But in the general appearance, this will come in handy. So mental status, active, alert, or drowsy. Any dysmorphic feature of Down syndrome. Ask about pickled, pallor icterus, and sign of dehydration. Now, sometimes in face-to-face exam, examiner can ask you that, what are you looking for in the sign of dehydration? So then you have to say that I'm looking for any sunken eyes, dry mucous membrane, any depressed anterior fontanelle. Also, I'm going to check for skin turgor and capillary refilling time, and if possible, then urine output. Okay, so these 5 or 6 signs are needed to check the sign of dehydration in a child. So capillary refilling time, skin turgor or skin pinch test, sunken eyes, mucous membrane, and anterior fontanelle. So after general appearance, then ask about vitals. So I would like to check the vitals: pulse, blood pressure, temperature, respiratory rate, and oxygen saturation. Now, pediatrics, every pediatrics physical examination should include asking about growth chart. It is very, very important, especially for vomiting cluster. It is important to rule out pyloric stenosis, because in pyloric stenosis, you will find out that child is not growing. That means child is not gaining weight properly because of the vomiting. So how we ask it from examiner, we will ask that, is the growth chart available, doctor? And if it is available, examiner say, yes, child falls under 50% of height and weight in terms of the age and sex of the child. So, or they will just say child in 50th percentile. So that's important. Then after that, you will start with 1 by 1 systemic examination. In here, because this is a vomiting and fever child, start with the neck. Check for any neck stiffness, because it is very important to rule out meningitis in a vomiting child who is having fever. So neck stiffness usually doesn't give you any idea if it is less than 18-month-old child. But more than 18-month or 2-year-old, neck stiffness is a good idea to check. After neck stiffness, you go to the ear, nose, and throat examination. Now, we are not going to discuss how to examine the ENT in here, because in respiratory system, we will have this done in detail. But to give you an idea, we will start with like this, that here I would like to do head to toe systemic examination, but first start with the ear, nose, and throat. In the ear, I would like to check for any discharge, any tympanic membrane redness or sign of inflammation. In the nose, I would like to check for any nasal discharge or any change in nasal mucosa. In the throat, I would look for any sign of pharyngeal erythema, any tonsillar enlargement, or exudate. Okay, so that's ear, nose, and throat. Don't get stressed about it now because we will discuss it in detail in the respiratory system. After ENT exam, then what is most important? Abdominal exam. So you'd like to do a full abdominal examination, starting with the inspection. On inspection, is there any visible distension, any visible peristalsis, or any visible mass? On palpation, any palpable mass or any tenderness? On auscultation, is the bowel sound audible or not? So why it is important? Visible distension is important for intestinal obstruction. Visible peristalsis sometimes can be found in pyloric stenosis. Even sometimes you can feel a lump in pyloric stenosis or intussusception. And bowel sound can be changed in intestinal obstruction, obviously. With the consent of the parent, I would like to check the hernia orifice, like to do a genital examination and per-anal inspection. So hernia orifice is very important, and always remember that you have to take a consent from the parent that you are going to check the genital area. And in that area, you are mainly looking for hernial orifice for any possibility of obstructed or incarcerated hernia, genital examination, especially to rule out any possible testicular torsion, and per-anal inspection. Sometimes it will give you an idea, especially if it is an intussusception baby. They can have a red currant jelly-like stool, and you can, if you just open up the anal area, you will see that the red currant jelly-like stool is coming out. So that's why we do the per-anal inspection. In children, we will not do per-rectal examination. Okay. And then you say that I would like to finish with all other systemic examination, including respiratory system, cardiovascular, and central nervous system. You don't need to ask it in detail. Examiner will say those are normal. And no physical examination is finished until you ask the office test. So is there any office test available, doctor? Especially any urine dipstick or blood sugar. In the urine dipstick, what you're looking for? You're looking for leukocyte, nitrite, and any red blood cell. But mainly for UTI, you are looking for these two. And you will get positive finding here. And that's how you know that this is a UTI case. Okay, so that's your physical examination for almost every vomiting cluster. So you just need to remember this format in your head. So you will start with the general appearance, followed by vitals and growth chart, then ENT examination and neck stiffness, followed by abdominal examination. Do not forget to check the hernial orifice and genitalia, and lastly, other systemic examination and office test. Ketone is not very important in here, but if you ask it, that is fine, because ketone can give you some idea about dehydration, and also if it is a DKA baby, that can also help you with that. So you can ask it, not a problem. So once you know that this is a urinary tract infection, how you are going to explain it to the mother. So Jenny, thank you so much for waiting. Now, according to the history and physical examination, and also we have checked your baby's urine, most likely your child is having a condition called urinary tract infection. Do you know what it is? Yes, doctor. We, like most of them, know what is urinary tract infection. So say that, well, let me discuss it in detail so that you understand why it is happening to your child. So it's an infection of the urinary tract caused by a bug. Let me draw a picture so that we can see what are the components of a urinary tract. So that's the kidney. And then from kidney, two tube-like structures come out, and then it drains into the bladder. and then urine comes out of the body through the urethra. Now, because this urinary tract is very close to the back passes, sometimes bug can easily enter into this urinary tract, causing infection and inflammation, and that manifests as fever, vomiting, and with a painful, smelly urination. Because it hurts or burns during passing urine, that's why your child is crying during passing urine. So far, you understanding me? Yes, doctor. Now, because your child is still 9 months old and she is considered to be a part of vulnerable group of patient, I would like to send your child to the hospital via ambulance. In the hospital, she will be seen by a child specialist for further evaluation and management. As the initial urine dipstick is just a screening test for the infection, most likely they will take another urine sample, probably by a method known as suprapubic aspiration, and then send it for culture to confirm the diagnosis. In this procedure, a needle will be inserted just below her belly button, and a sample of urine will be collected. Please don't get scared. It will be totally pain-free and will be done by a very experienced child specialist. So that's the thing, because it's a 9-month-old child. You can't rely on urine dipstick to confirm the diagnosis. So especially any less than 1-year-old child, you have to do a suprapubic aspiration to confirm the diagnosis. And you can't do it in a GP setting, so you have to send the child to the hospital. Okay, so once you discuss about the investigation, then say that most likely after the urine has been taken, specialists might also start your child with antibiotic to fight the infection and paracetamol to address her fever. Now, the next thing depends on the specialist that if they want to do any more investigation to find out any structural abnormality causing this infection. Most of the time, if it's just a first-time infection, usually they don't do any investigation. But in case of recurrent urinary infection, specialists might decide to do an ultrasound of her waterwork to exclude any structural abnormality. And if there is some abnormality they have found in the ultrasound, a specialist might also want to do another test called micturating cystourethrogram, where a special dye is inserted into her urinary tract to look for any abnormality. But as I said, that because she has got it for the first time, it's very unlikely that she will require this extensive investigation. But I'm just giving you the possibilities. And obviously, this will be decided by the specialist, and it will be discussed in detail with you. Please don't worry, most of the children with a urinary tract infection make a good recovery without any complication. I would like to advise you to change some of the hygiene advice or to change some of the things, especially always try to wipe from front to back, give her ample amount of fluid. And once you are discharged from the hospital, I would like to review her again. In between that, I will give you some reading materials about this urinary tract infection and what you should do to make sure that it doesn't happen again in the future. Okay, so that's the 4R, that how we finish at the end. Because you are sending the child to the hospital, that's 1R, which is the referral. And then you wanted to review the child after hospital discharge. You have given some reading materials also. You don't need to give red flag because you are sending the child to the hospital already. So these are the 4R, that how we finish most of the cases: referral, review, reading material, red flags. Now, this is how the management of UTI should be done in the exam. The question is that, should we talk about this ultrasound and MCUG? Yes. The way I said, it covers you because you say that most likely it will not need it. It will not be needed because it's the first time infection, but sometimes a specialist might want to consider it. In that way, you are actually letting the examiner know that you know about these investigations and that's how they like it. Okay. And we don't collect urine in a bag because bag specimen is very contaminated, and it's never ever we can rely on a bag specimen. Yeah, SPA, like especially if the child is less than 12-month old, if you need to confirm the diagnosis, then suprapubic aspiration will be needed. So it's not about recurrent UTI. For recurrent UTI, usually you have to do this ultrasound and MCUG, but again, like you just discuss it in here as part of the management, because there were some candidates who did not discuss this thing and ended up failing the case. So that's why we have added it in here, so that you can just explain in a way that suggests that you know about it, but again, you are not recommending it. All right, any question, guys? So that's all about the urinary tract infection. And also, I would advise you to go through the urinary tract infection guideline from RCH just to get some idea about it. All of you has read it during your MCQ preparation, but again, just to get an idea, like if any questions they ask you, you should be able to answer those. Now, the guideline is, let me discuss this one a little bit. I know that this is a little confusing. So the guideline is that if it is a child less than 1 year old, you have to do SPA, suprapubic aspiration. Usually children more than 4 year old, then you can do that midstream urinary collection, MSU. And because the child usually can give the urine on request, so MSU will be the usual appropriate approach. Now for this pre-continent child, 1 to 4 year old, there is one other thing that you can do, which we call clean catch urine. So if parents are able to catch the urine, then that's one of the other way to avoid SPA in this child group. Okay, clear, Dr. Priyanka? Usually, do we need to do blood glucose in a GP setting in a child? Normally, in here, we would not do it because child most of the time does not tolerate this kind of thing in GP setting. So it's not very, like in ED, they can do it, but for GP setting, not important. But for exam purpose, we can ask it because you can get some information. And what kind of antibiotic you give to the children in UTI? So the preferred one is cefalexin, and you can give it as a 3 to 7 days course. So normally, if it is not very unwell child, then 3 days. If it is a recurrent infection or unwell child, you can give it for 7 days. Okay. All good. Next is gastroesophageal reflux. You are a GP and a mother brought her 4 months old baby girl. She says the child vomits after feeding. There are no other symptoms. Mom thinks that bottle feeding will be better for him. So you have got a 4-month-old child who is vomiting after feeding. So you already get some idea that it's most likely a reflux. Task is same. So now in this case, you have to understand a little bit about the pathophysiology of this reflux. There are two terms that we use for children. One is gastroesophageal reflux, another is gastroesophageal reflux disease. For gastroesophageal reflux, it is a physiological thing that happens in children because children's lower end of the esophagus, it's very immature and it does not have enough strength to prevent the acidic reflux. So each time you feed them, they usually end up having some reflux or regurgitation. And that is normal. It's not abnormal, it's a physiological thing. So we discuss gastroesophageal reflux as passage of gastric content into the esophagus, which is a physiological process, occurs several times in a day in healthy children. And majority of the child get over it by 12 months of time. So after a year, this will be totally normal. So nothing to worry about. But if children with gastroesophageal reflux, they develop any of these symptoms, then we call it gastroesophageal reflux disease. So what are those? So these are the questions you have to find out in your history. So if there is pronounced irritability with arching of the back, so if the child is like having an arching of the back, if refusal to feed, losing weight for that, having hematemesis, chronic cough and wheezing episodes, and apneic episodes. So if you get any of these features, then the diagnosis becomes gastroesophageal reflux disease. Now, in the history, everything will be similar. There is nothing you have changed from the format that we have, but just make sure you add these questions in your history. So especially in the well baby question, you can ask about it, that is he sleeping and feeding well? So you will get the answer of refusal to feed. You're also asking about any weight loss. You can ask at that time that you're asking about is he active, alert, or drowsy? So you can get this irritability from here. At that time, you can ask that, have you noticed that he's having any arching of the back, or sometimes he is bending his back? We already asked about hematemesis. Remember the CCVO, any blood in it? So that's hematemesis. Only thing that you have to add in the history is these two things, chronic cough and apnea. So you can ask at the time that, like in any time during your history, you can ask that, have you noticed that he's coughing a lot, especially at night time, or especially when you put him on his back? And for apnea, we ask the question that, have you ever noticed that he stopped breathing for a few seconds? So he stopped breathing for a few seconds, that is how we ask apnea. So these two questions you just have to add in your history format. Okay? So the positive points in history was child vomits after feeding, and it's not acute presentation. It's been going on maybe just after birth. So it's a 4 months old child, and for the last 3 months, he's having this vomiting. So it's not something acute. And the content is just the milk. Sometimes even it can be projectile, but child will gain weight. Child will grow well. So just because if you get that it's a projectile forceful vomiting, don't think that it is pyloric stenosis. It can be reflux as well. The main thing is it affecting the child weight? Okay. So vomiting after feeding, white color or milk content, and then child is gaining weight and not losing weight. So that's the only history that you are going to get. All other physical examination will be normal. Very important is the growth chart. In growth chart, you will see that child is growing well. And you will not get any sign of reflux disease. So same like before, history and physical examination, only add the symptoms of reflux disease. So how you are going to explain it? Say that most likely, according to the history and physical exam, your child is having a condition called gastroesophageal reflux, not reflux disease. So that's the tricky part, because in adult, we don't say gastroesophageal reflux. We say gastroesophageal reflux disease. But for children, the term is gastroesophageal reflux. If you say reflux disease and there is no other symptom of reflux disease, you fail the case. Okay? So even though it sounds very easy case, that's one of the trap. So explain what is reflux. So let me draw a picture for your better understanding. So this is the lower part of, or you can say this is his food pipe or esophagus, and it connects to the stomach, and then it connects to the gut. The lower part of the food pipe, where it's connected to the stomach, is poorly developed in babies. And that is the reason why the milk in the stomach flows back into his mouth, especially when you put him down. Please don't worry, it is a very common condition where baby vomits after each feed, but otherwise he thrives well, gain weight properly. This condition gradually improves with time, especially after introduction of the solids, and majority of time, by the age of 12 months, usually they become totally symptom-free. But in between that, if it is really bothering you, if you think that he's not able to keep anything down, then I would recommend you to give him some small frequent feeding, not a huge amount of food at one time. Decrease the duration of feeding along with time in between. And the most importantly, you can thick the food or breast milk by adding some thickeners called Gaviscon. That's a good one. Like they can just add some food thickeners, and because if you give a thick food, it is very hard to come back again to the mouth. You can also elevate the head of pot by 10 to 20 degrees. After each feeding, please don't put your baby immediately to sleep. Carry him for a while and put him in cot with the head elevated. We highly recommend breast milk because it is best for your baby's development and immunity. Now, if this maneuvers or modification doesn't help in few weeks' time, then I can refer your child to a specialist who can consider putting on some acid suppressant therapy. But it is very unlikely that your baby will need that. Most of the time, with some of the modification that I have discussed, children usually get better. And I would assure you that as long as you see your child is growing well, is feeding well, gaining weight, there is nothing you need to worry about. And I'm going to review him regularly. I will give you reading materials about everything that I have discussed today. But in case if you noticed that the intensity and frequency of vomiting has been changed, is getting very irritable with arching of the back, is refusing to feed at all, losing weight, developing cough or some musical noise from the chest, or if he stopped breathing for a few seconds, these are the signs of reflux disease or the severe form of this condition. In that case, please bring him back to me immediately. Otherwise, I will just review him every 4 to 6 weeks' time and see how he is doing. Okay? So that's about reflux disease. Now see that with just only one format, we are totally skipping the history and physical examination. Only thing that we need to remember is the management, and that's not very hard, right? So that's the trick of having a cluster in your head, having a format in your head. It becomes so important and it becomes so easy at the end. And you don't need to memorize every case as a separate case. All right. So we have a lot of other cases to discuss tonight because we are going to finish it today. So the class will be a little, I think like we will do it as a 2.5 hours today, or maybe a little bit more. So just stick to the time, please. If you need to have some drink, coffee or tea, just have it and just give me 10-minute break. Okay? Thank you. All right, everyone, let's start again. The next case is pyloric stenosis. So for pyloric stenosis, the case will come similar like the other cases. So you are a HMO in the emergency department. See that now this is coming in the emergency department. So you already know that it is not something like a reflux. Reflux will never come in an emergency. It's a 6 weeks old baby coming to you with vomiting. So, and pyloric stenosis vomiting usually will not be there for a long time. The child usually comes within weeks or sometimes even within days because it becomes so projectile and forceful and child becomes unwell quite easily. So, and it's very common in this time, like 4 to 6 weeks old baby. So the finding is, in history, you have found that it's from the 4 weeks, from the 6 weeks of age, child started to have this vomiting. The vomiting color is non-bilious. That means it's a whitish one, not greenish vomiting. If you get a greenish vomiting, that means it's not coming from the stomach, it's coming from the gut. So duodenal atresia, intestinal obstruction, those vomiting will be greenish or bilious. But pyloric stenosis, reflux, this vomiting, it is most likely a non-bilious vomiting. And it is becoming progressively more forceful at the time. Child hungry after feeding, and the most important finding is that child is losing body weight. In the physical examination, child might be dehydrated, so don't forget to ask about sign of dehydration in this child. You can get on inspection of the abdomen, you can see gastric peristalsis, and usually these are kind of waves of muscle contraction, which starts from the left upper quadrant and goes towards the right lower quadrant. So visible gastric peristalsis, it is one of the signs of pyloric stenosis. Now, it's not always you will get it. In some children, you might not even get it at all. And when the child cries, then only you can see the gastric peristalsis. So it can happen. And also on palpation, you can feel a pyloric mass. The pyloric mass is best felt in the right upper quadrant, and it's kind of an olive-shaped mass. Sometimes we also ask for a feeding test. That means we ask the mother to feed the baby, and we see that what happens after feeding. So if the child immediately vomit and the vomiting looks like projectile forceful, then that means it's a positive feeding test. Now, it's not always we need to do that. So if you don't ask it, it's not a problem. But sometimes in the physical examination finding, you can get that positive feeding test. And that suggests that it is pyloric stenosis. So we're looking for this physical examination finding in here. So visible gastric peristalsis and palpable pyloric mass. So the history is same, physical examination is same, nothing is different. Your management. So most likely, according to the history and physical examination, your child is having a condition called pyloric stenosis. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So you draw the picture like this is the esophagus, then that's the stomach, and this is the first part of the gut. So draw something like that very quickly. So say that when you give breast milk to your baby, the milk goes from the mouth through a tube-like structure called food pipe to the stomach. And from this stomach, milk then goes to the small gut. In pyloric stenosis, the lower end of the stomach, which is called pylorus, it gets narrowed. And as a result of that, milk or whatever your child have, it cannot go down to the small gut. And then child just need to vomit it out. And because of massive vomiting, he is also losing fluid from his body. And that's the reason he's not gaining any weight. Now, because he's not able to retain anything, and on the top of that, He seems quite unwell and dehydrated. This is an emergency condition. And unfortunately, I'm very sorry to say that most of the time, it requires an operation to fix it. That's why I'm going to call the ambulance. Now in here, if you say ED setting, you don't need to do any of this. If it's a GP setting, then you will call the ambulance, especially arrange for a pediatric retrieval team to come and pick the kid up and take him to the tertiary hospital. If it's an emergency department, then you just say that this is an emergency situation because your child is losing weight and he's vomiting everything out and he's dehydrated. So we need to admit him to the hospital. I will call my senior who will come and review him also. And also a pediatrician or a child specialist is going to come and review him. In the hospital, the specialist might also want to do an ultrasound to confirm the diagnosis. We might also need to do some blood tests to check his salt and mineral balance. As your child seems dehydrated, we are going to start him on IV fluid. And also, please do not feed him from now onwards because his vomiting might just get worse with it. If your child keeps on vomiting like this, and then we might also need to insert a tiny plastic tube through his nose down to the stomach to remove any of the remaining contents from the stomach to stop the vomiting. Once your child is stable, most likely an operation will be needed to fix the problem. Your child can usually start eating and drinking within 6 hours of the operation. Once the problem has been repaired by operation, it is unusual for this to come back again. Jenny, I do understand that you are not expecting any of this today, but I want to assure you that your child is going to be fine, and we'll do our best to manage his problem. And I need you to understand that if there was anything medically that we could do, we would not go for this operation. But this is the only management that we have for this kind of condition. And left untreated, these things will just get worse and worse. And your child will not be able to retain anything. So it is better to do it as soon as possible. If you want to call your friends, your partner, or anyone, I'm more than happy to do so. And if you have any questions, just feel free to ask me at any time. We are here to help you and your baby. We'll take care of him, and he's going to be fine. The specialist will discuss in detail about the operation and the indication, and if there is anything else that you need to know. Also, he will discuss about the risk of the operation with you. If you have any questions, just let me know. I will come and discuss with you again. Okay, so the last few things that you are going to say in here, it will make your exam pass or fail. That means this station will be passed or failed based on what you say at the end, most of the time. Because if you say like a parent just at the moment, they just know that their kid who is 6 weeks old is going to have a surgery. It is so stressful for the whole family. And they need you. And make sure that you are there for them. Make sure you discuss with them properly that this is why it is needed. It's not like we are just doing it for without any reason. It is the most important thing. And we have to do it because otherwise the child can have a life-threatening event. Okay? So make sure that you know how to discuss these things, because when the management of such a case comes in exam, they usually mark you based on your approach. Okay? So just to summarize the management, you explain what is pyloric stenosis, discuss it in detail, that what is pyloric stenosis and why it is important, because he's losing fluid, salt and minerals from his body. And if it's a GP setting, then you are going to call the ambulance and send the child to the hospital as an urgent process. So call the emergency retrieval team so that they can come and pick him up. If it's an ED setting, you are going to admit the child, call your senior and also the pediatric register to come and review the child. And most likely they will need to do an ultrasound to confirm it. In between that, you can start the child with IV fluid, advise not to feed at the moment, and talk about a little bit about the NG tube, especially even after stopping the feeding. If child keeps on vomiting, he will require NG tube. And once the child becomes stable, then the operation will be needed. You don't need to discuss in detail about the operation risk, procedure, or complications. It will be done by the specialist. But you need to make sure that you say that why it is emergency thing, and say that a specialist is going to discuss everything in detail with you. Okay, and lastly, the reassurance part is very important. All right, guys, any question with this one? For those of you who are in Facebook Live, you guys can just write anything that you want to ask in the comment section. I have it open in my phone, so if you want to ask anything, you can write it in the comment section. I will answer in that way. Okay, moving on to the next one, intussusception, another important topic for exam. So you are a HMO in the ED, 5-month-old boy with multiple episodes of screaming for the last 6 hours. So intussusception comes very acutely in exam. And it's on not only just exam, in real life also, like within few hours. He has vomited twice in the last 3 hours. History, physical examination, and explanation. So history, obviously, you need to make sure if the child is vitally stable or not. And start with some reassurance and ask about the screaming episodes. So your presenting complaint is screaming. So can you please tell me a little bit more about these screaming episodes? Since when? Is it for the first time? Is there anything particularly happened before this episode? Like child can have something inhaled, like a foreign body inhalation or ingestion can happen. We don't know. So we just need to ask, is there anything particularly happened just before this episode start? Is it continuous or episodic? How many episodes so far? Does he draw up his legs while having these screaming episodes? And does he turn pale? So these are the two specific questions for intussusception. After that, you also know that the child is vomiting for 2 times. So ask all the vomiting question. And then you go to the differential. So mainly follow the differential of vomiting. So bowel and bladder. So ask about bowel habit. Ask about the waterworks. You can also ask about incarcerated hernia, which means have you noticed any lump or bump in the tummy or especially in the groin? And then just non-infectious causes of vomiting. In intussusception, you can also get loose stool or red colored stool. So when you ask the bowel habit, you will ask that is there any diarrhea or constipation? In that case, you can get loose stool positive. Lastly, finish with well baby binds, past medical and family history. Physical examination is same, but on your systemic examination of abdomen, you might find some findings. So on inspection, you're looking for any visible distension, any visible peristalsis, On palpation, you are actually feeling for any palpable mass. Now, in intussusception, you can feel a sausage-shaped mass, and sometimes when child cries, that mass becomes more palpable. So if you are sure that this is an intussusception case, and you asked it from the examiner that, is there any palpable mass? Examiner says no. You can then ask again to your examiner, when the child cries, can I feel any mass? Sometimes at that time, examiner give you that, yes, when child cries, you can feel a sausage-shaped mass. Okay? Sometimes you can also feel an emptiness in the right iliac fossa. You can ask about tenderness and auscultation. Sometimes you can get an alternating high-pitched bowel sound with absent bowel sound in intussusception. Okay, so that's the finding of intussusception. And obviously, you will be looking for hernial orifice perianal inspection for any red current jelly-like stool. Very important. There was a case years ago where they have put a dummy, like a doll, in the face-to-face exam. There was nothing positive in the history, just vomiting. And in this case, the vomiting will be a green-colored vomiting. Okay? And even you don't get screaming episodes, like very vague history. One task was that do per-anal inspection after finishing your history. So you did the history, you are not sure what it was, and you also asked physical examination finding from examiner. And when you went for per-anal inspection, you actually need to open the diaper. And when you open the diaper, you can see the red currant jelly coming out of the dummy or doll. Okay, and that's the only thing that was positive. And if you know what you're looking for, then you will be able to diagnose it. Okay, so that's important. So we already know the positive points for intussusception. The children usually present with episodic screaming or crying. Because they're in severe pain, they drop their legs to the chest. During the episode, they look pale. They can also get a bloody diarrhea, classic red currant jelly-like stool. Dehydration is common. And sometimes before this episode, they can give some history of upper respiratory tract infection. Physical examination, we already know, so that's fine. Management. So based on the history and physical examination, most likely your child is having a condition called intussusception. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So intussusception drawing is very hard, right? So only thing that you can do, draw this, and with this, just draw another one. That means it's actually the sliding of one part of the gut into another. Because of this sliding, the bowel can get blocked or obstructed, leading to this excessive pain and vomiting. So that's the only thing that you need to do. You don't need to go to the detail of intussusception, which is very hard for a patient to know. Now, because there is obstruction of the bowel, that part of the bowel is not getting enough blood supply, and that's the reason it is an emergency situation. We need to admit your child and involve a child specialist in his care. In the meantime, please do not give him any food or drink. And also, we are going to insert an IV line to start him on IV fluids. The specialist might want to order an ultrasound and X-ray of the tummy to rule out any other possibilities. Once the diagnosis is confirmed, the treatment is done by a specialist, a radiologist, and a pediatric surgeon. Initially, they might want to try a procedure called air enema, which is passing a small tube at his back passes through which air will be passed to unblock this obstructed gut. Please do not worry. Throughout the procedure, your child will be monitored by the specialist and he will be in sleep. So you will not get any pain. You will not even know what's happening. If this procedure is not effective, unfortunately, the surgeon might want to go for operation as well. Please don't worry. Now that you are here, we will give our best management to make him as comfortable as possible. And then lastly, say all of these things like pyloric stenosis, like, Jenny, I know that you are not expecting any of this today, but I really appreciate that you brought him today, and now we know what's happening. If you would not bring him, it could be life-threatening also. But now, most likely with just air enema, he will be fine. And in case if even he needs to have a surgery, we have the best surgeon in here. And obviously, we are going to make sure that your child becomes fine and comfortable just like before. If you want to talk, or if you want me to contact your friends, relatives, or your partner, please let me know. I'll be happy to do so. If you have any questions, please ask me multiple times. I will answer you as long as you want to ask. And also the specialist will come and talk to you about the further management and investigation. If there is anything that you don't understand, or if you have doubt, please do not hesitate to ask us. Okay, so something like there is no one or two way to do this. Whatever you say, it should sound that you care for the patient, you care for the family. As long as you are doing that, you are fine. Any question with intersusception? So how many cases we have done with the same format already? We have done reflux, pyloric stenosis, UTI, intersusception. 4 cases, right? Now the next one is incarcerated hernia. Incarcerated hernia comes in 2 ways in exam. This one is the most common one. A 5-month-old baby came to your GP clinic with his mother because of sudden onset intermittent screaming with a few episodes of vomiting. So it looks like intersusception case, but it's not. So that's why it gets confusing in the exam, because incarcerated hernia child can also present to you with these screaming episodes. Older brother has got recent onset of gastroenteritis. That's just a trap to make you confused. That's one question, which is acute condition. There is another one, 3-month-old irritable baby for 3 weeks. Mother noticed a lump on the inguinal area today. And this is actually just a reducible hernia case, but this one is irreducible or incarcerated hernia case. So your history will be totally same, nothing to add here. Physical examination also same. When you come for hernial orifice examination, examiner will give you a picture of incarcerated or obstructed hernia. So you will see there is an inguinal hernia, which looks very red. And then you just need to ask to the examiner that, dear examiner, I would like to examine this hernia. I would like to know if it is tender, if it is irreducible, and if there is any audible bowel sound that I can hear. 3 things that you need to ask. Is it tender? Is it reducible? And I would like to auscultate for any bowel sound. Okay? If it is an irreducible or incarcerated hernia, the overlying skin will be erythematous or red. It will be very tender and irreducible, and there will be no cough impulse. So if it is like an older baby or older child, then you can ask for cough impulse also. And also, sometimes you can get some bowel content in that hernia. So you can just ask for it, that if there is any bowel sound audible in here or not. So in the management, from history and physical examination, most likely your child is having a condition called incarcerated hernia. Do you know what it is? No, doctor. Well, a hernia is a protrusion of part of gut or fatty material through a weakness or opening in the tummy well. It is usually seen as a bulge or as a lump under the skin in the groin area. In a simple hernia, the bowel or the fatty content are able to move freely in and out of the defect, which we call reducible hernia. But if somehow the part of the content becomes trapped and cannot return to the tummy, then it is at risk of having its blood supply cut off. And in that case, usually the child presents with severe episodes of crying and screaming because they're in a lot of pain, because that part of the gut is not getting any blood supply. And because of that, child also starts to vomit. This is what we call as irreducible or incarcerated hernia. Do you understand me? Yes, doctor. So that's the reason this is an emergency condition. We need to admit your child right now. He will be seen by a child specialist for further management. As of now, please do not feed him or let him drink any water. We are going to put an IV line and start him on IV fluids. Most likely, a specialist will need to go for operation to put the blocked gut back inside. Please don't get scared. We will do our best to manage his condition. And it is not very uncommon in children, but unfortunately, it is now in a blocked position. So we have to go for surgery as soon as possible. But we have a very good team of doctors here. Your child is going to be fine. And obviously, you have to say some nice words like before in this case also. Okay, so that's incarcerated hernia case. Any question? No, Dr. Priyanka, we don't need to do rectal exam in pediatrics. Yeah, it's most of the time inguinal hernia comes. Usually femoral hernia or other hernia does not come in the exam. Any question, guys? All good. Next, duodenal atresia. I think we did very quickly. Like I think this is the last topic for today. Good. So you are working in a small country hospital as an HMO. You have been called to talk to a 27-year-old mother, Janelle, who gave birth to a baby boy 24 hours ago. So you are in a small country hospital as a HMO. She started breastfeeding, but he has vomited several times, some greenish fluid. And he hasn't passed meconium yet. The neonatal checkup did not reveal any pathological finding, and especially anus was present. An abdominal X-ray is provided. You have to take a brief history from mother. X-ray findings should be explained to the mother and discuss the most likely diagnosis and management. Okay, so we have got a 24 hours old baby and he's having greenish vomiting just after breastfeeding. So this is exactly how duodenal atresia presents in exam. Why it is not esophageal atresia? Guys, just by looking at this question, you can say that it's not esophageal atresia. Why? Yes, Dr. Kirti, very good, because it's a greenish vomiting. So greenish vomiting will not be there in esophageal atresia, right? Because, yeah, so if it's coming from the gut, like duodenum, then only it will be a greenish one. Very good. Now, this is the X-ray that is provided. So we call it double bubble sign. See this bubble and this bubble? That is what we call as double bubble sign. And it's very commonly you will find it in duodenal atresia type. So in this case, it's a 24 hours old baby. So mother just had a delivery. So say something nice to her. So say that, hi, Jenny, this is Dr. Ashan, one of the doctor here. It's very nice to meet you. And congratulations on your baby. It must be exciting for you. But I'm very sorry to hear that your baby has been vomiting some greenish color fluid. Please don't worry, I'm here to help you. I'm going to ask you a few questions about it. But first of all, I will make sure your child or your baby is vitally stable. So you just ask from the examiner if he is stable or not. And then you can ask to the mother, thank you so much for waiting, Jenny. So let me just ask you that, are you feeling all right after delivery? Do you have your partner or anyone with you here? Do you need me to call someone to be with you? No, doctor. Are you having any pain anywhere? No. So can you please tell me a little bit more about the vomiting? When did it start? How many hours after delivery? How many episodes so far? If you already know the color, then you don't need to ask it. If you don't know, then you have to ask the color. Is there any blood you have noticed? What does it contain? Is it small or amount? And is it foul-smelling? Have you tried to feed him? Yes. And does it come just immediately after feeding? Yes, doctor. And then you just ask all other vomiting questions one by one. Okay. And finish with will baby, binds, and family history, and if there is any known medical condition. So same thing, you just need to start a little bit nice and slow. That's all about. In binds, there is one thing that we ask, because duodenal atresia very commonly associated with Down syndrome. So in the binds, ask a little bit that how was the pregnancy? Did you have all of your antenatal test? Yes, doctor. Did you have your Down syndrome screening? So they would say that, no, doctor, I did not. Okay, so Down syndrome screening is one of the key steps in here to ask. So then you have to just finish the history and then explain the X-ray to the mother. So explanation will be very simple. You can't use any medical jargon in explanation, and it's very hard to explain an X-ray in this way. So very nice and simple. So say that, Jenny, Jenny, we have done an X-ray of your baby's chest and the tummy to find out why he is vomiting. I'm going to explain it to you. If you don't understand, please ask me multiple times. I'll be happy to discuss about it. So as you can see that this is an X-ray of your baby's lower chest and the whole tummy. In X-ray, some structures look black, some looks whitish. The blackish are mainly which contains air, and the whites are mainly which are bony structure or something which contains fluid or blood. Are you with me so far? Yes, doctor. Now, if you look at here in the top part, you can see on the both side there is some blackish shadow. This is your baby's lung. And in the middle, that's the heart. Now, if you come a little downward, that's the tummy. But you can see that there are two very large circular shadow, like a blackish shadow. Can you appreciate that? Yes, doctor. This is what we call as double bubble sign. And that's usually we find out in a specific condition called duodenal atresia, or it is also known as a small bowel obstruction. Let me draw a picture so that you understand it. So when you give breast milk, your milk goes down from the mouth to a tube-like structure called food pipe. And from there, it goes to the stomach, and then it goes to the small gut. The first part of the small gut is known as duodenum. In your child, there is an absence of this part of the small bowel, and that is what we call as duodenal atresia. Because this is absent, the milk that you are giving, it cannot go down below. That's why it's just coming out of his mouth as vomiting. I'm very sorry that this is happening to your child. It is stressful for you. But it is not very uncommon. The exact cause why it occurs, it's not known. But because your child is not able to retain anything, is losing all the fluids and salts and minerals from his body. And that's why it is a surgical emergency. Because we are in a rural hospital, we can't treat this kind of condition in here. We don't have specific equipment, nor we have a experienced surgeon in here to do this kind of operation. That's why I'm going to refer your child to a tertiary hospital as soon as possible. I'm going to arrange an emergency transport system, and we are going to send your child to the tertiary hospital via air ambulance. Your child will be assessed by a pediatric surgeon for further management. In between, I'm going to insert an IV line, take some blood, and start him on IV fluid. Please do not feed your child at the moment because he will just vomit it out. I'm very sorry to say all of this, Jenny, because I can't even imagine that what you're feeling right now, because your baby is just 24 hours. And if I were in your place, I would exactly have the same feeling that you are having now. But I want you to know that we are here to help your kid. And we'll do everything possible in our hand to make sure he becomes comfortable and he gets the best possible management. Okay, so say something nice and say that the surgery is the only way to do it. Okay, so that's the management of duodenal atresia. Any question? So that's actually the end of the today's vomiting cluster. We did really good. Normally we need more time, but it's good that you guys, I hope that you guys understood this. And you could see that we have done 6 or 7 cages just by using one single format. And there are candidates who have to do these cages as separate. And that is very unfortunate. Like there are a smart way to learn. And if there is no one to guide you, then you just waste a lot of time. And remembering 300 cages, it's not easy. I would say it's impossible to remember 300 cages because that's something which happens at the end of your preparation. So with this kind of cluster-wise approach, we can make this precise. We can make this very small, and you can easily remember it. And trust me, our students, they just use the format in the exam. And even if there is new cages appear in the exam, the format already is there. And you always know what you are going to get. You always know the diagnosis because you know the cages and you know the symptoms, you know the examination findings. So whatever case come in the exam, you will be able to diagnose it. If you're able to diagnose it, you can manage it also. And management is also same. You explain the condition, and then you say that if it is urgent or just a normal thing. If it's urgent, you send them to the hospital. In the hospital, seen by the pediatrician, some investigation will be done, and then surgery if needed. In between, IV fluid, do not feed anything. If child is vomiting a lot, then NG tube. That's the management. So it's not very hard, right? So now this is the end of our free 2-week session. If you still want to join the course, make sure that you contact us as soon as possible, because we are going to have our orientation session on Wednesday, I think on 20th of July. So please make sure that you start the process and contact us so that you can join that session, because if you miss those kind of orientation session, it becomes a little bit of confusing for you that where to go, and you will feel like something is missing. So that's why I always say that come to the orientation session. We discuss everything, how to use the software, how to manage your time, and what you need to do to prepare for the clinical. So those kind of things are needed. So make sure that you contact us as soon as possible. And because this is our last free 2-week session, there will be no more classes on the Facebook Live. So all classes are usually happen on Zoom only. So, and that's a part of the course, obviously. We are going to just show you the course details once again. We have shown you like when we started the first 2-week session, and we'll end with the same video as well. Okay, so give me just a minute. So did you guys enjoy the free 2-week session? That's the question. All right, so let's watch the video a little bit, and then we'll finish the class. All right. So that's about it, right? So that's all about the course. If you guys have any questions, then just ask. You can ask it here now, or always you can contact us as well. All good then. So that's all about it. We'll finish it here tonight, and we'll see you on Wednesday. Thank you all. Have a good night. Bye. And best of luck.